Hello, good morning, friends. Today, the topic is poliomyelitis. So, this is very important accept in needs of community because anytime when we talk about the vaccine, the disease come to our mind is poliomyelitis. See these children, very pathetic because this can be prevented by giving the vaccine. Okay, so. So we'll come to introduction. So polio virus comprises of three serotypes, type 1, 2, 3, all of which cause paralysis. Type 1 is most responsible for illness, type 2 is rarely involved. It mostly affects the children under 5 years of age. So this is a new terminology, new one, because those are wild polio virus. What happened? For the eradication of poliomyelitis, we started to give vaccinating our children with OPV. But there are some limitations of this virus series. While OPV is preferred for eradication of poliomyelitis, the virus may retain neurovirulence, resulting in vaccine-associated paralytic poliomyelitis. That is, one of 1.5 million OPV recipients, means children, will get this VAPP, that is vaccine-associated paralytic poliomyelitis. And one more is further outbreaks of paralytic poliomyelitis may be caused by a virulent strain of poliovirus formed by the mutation of OPV, chiefly OPV2, called the circulating vaccine-derived poliovirus. So these are the limitations because even vaccine strains are causing the two types of disease, VAPP, vaccine-associated paralytic poliomyelitis, and another is circulating vaccine-derived poliomyelitis. If you have somebody seen the news in 2006, so there usually will surveillance goes for poliomyelitis in Telangana in 2006 around that time. So they detected vaccine-derived poliomyelitis. So they have huge campaign was done. Nearly 4 lakhs of people are immunized with IPV. Yeah. So the surveillance is will go yearly because poliomyelitis we need to eradicate. So you see, it is most often caused by acute onset flaccid paralysis of the lower limbs. Acute onset flaccid paralysis of limb means lower motor neuron. Yeah. This condition was considered in the past as one of the most feared infectious diseases because of the permanent residual paralysis and disability. Yeah, still we are seeing some of the polio patients roughly 40 years of age at present. So still they need support. Yeah, clutches they are using. But the pathetic is we can prevent this disease by vaccination. With intelligent use of available polio vaccine, the disease has become a rarity. And Pakistan, Afghanistan, and Nigeria are the only endemic countries in the world. Okay. So at present, we are already at vaccine-associated paralytic poliomyelitis, that is VAPP, and vaccine-derived poliovirus VDPD are occurring in many countries. WHO aims at global eradication of both wild as well as vaccine virus causing poliomyelitis. How we eradicate wild? By giving polio vaccine. How can we eradicate vaccine virus causing poliomyelitis? By giving IPV, that is inactivated polio vaccine, that is killed vaccine. We will come to know. Yeah. In the coming slide, you will come to know. So we'll go for epidemiology. So poliovirus is highly communicable disease for which human is the only reservoir. That's why only we have eradicated the poliovirus. It multiples in the intestine and it is spread via fecal oral route. The average incubation period is 7 to 10 days. It variable ranges 4 to 35 days. The maximum excretion of virus occurs just before the onset of paralysis and during the first 2 weeks after the onset of paralysis. However, the virus is excreted intermittently up to 2 months after the infection. Okay. For this only AFP surveillance, we have to collect the stool at least 60 days of onset. Yeah, this is the reason. But most is within 2 weeks of paralysis, but it will be excreted intermittently up to 2 weeks. Yeah. So etiopathogenesis. The virus can remain active for several days at room temperature and can be stored indefinitely frozen at -20 degrees. It is rapidly inactivated by heat, chlorine, and ultraviolet light. The most frequent causes of epidemic polio virus is type 1, followed by type 3. Wild type polio virus 2 was eradicated from the world in 1990. So, following eradication of polio virus in the most part of the globe with oral polio vaccine, there is emergency of VAPP, means vaccine-associated paralytic polio, and vaccine-derived polio virus, which is a now leading cause of acute flaccid paralysis. Okay. So, the primary site of replication is small intestine and the regional lymph nodes. Polio virus, which probably access the CNS through peripheral nerves, primarily affected the motor neuron cells in the spinal cord, that is anterior horn cells. It causes lower motor neuron type of palsy, yeah, that is flaccid paralysis, and the medulla oblongata. So, infant born to mothers with antibodies are protected naturally against the paralytic polio for a few weeks. Okay. Active immunity after natural infection, including inapparent and mild infection, is probably lifelong, but protected against the infection serotype. So, this is specific to the serotype. Yeah, that's why even they get the polio virus, we used to give polio vaccine. We used to give oral polio because we don't know which serotype it has caused. So, even if the child get poliomyelitis, we have to vaccinate them under 5 years, up to 5 years of age. Okay. Therefore, polio immunization is necessary even after an attack of poliomyelitis to prevent from other serotypes. Okay. This is pictorial representation because the mode of transmission we know that is fecal-oral route. Yeah. So even oral polio virus we could give to the mouth, in the small intestine, mesenteric lymph node, cervical lymph node, access blood-brain barriers, and affected the anterior horn cells and the medulla oblongata. So clinical infection, clinical manifestation. How? In 90 to 95 of an infected individual, polio virus infection is inapparent. Yeah. So in the remaining 5 to 10, one of the 3 symptoms may occur. Okay. So nobody knows whether they get infected with polio virus, 90 to 95%. And remaining 4 to 8%, it called abortive polio, like a normal viral infection. It cannot differentiate whether it caused by which type of viral infection. By a viral illness like low-grade fever, sore throat, vomiting, abdominal pain, loss of appetite, and meals. It will like a viral prodrome. So abortive polio. Recovery is rapid and complete, and there is no paralysis, and nobody knows this. And then is non-paralytic polio. Non-paralytic polio occurs in 1 to 2% of infection. It is characterized by headache, neck, back, and leg stiffness, which occur several days after the prodrome. So it's similar to the aseptic meningitis. Yeah, presentation of other aseptic meningitis, and recovery usually occur within 2 to 10 days. Means there is no residual paralysis. Yeah, child will be normal as usual before the polio virus infection. So this comes the dreaded one, paralytic polio, which occurs in 0.5 to 1% of infection. Yeah, symptoms occur in 2 phases, minor and major. Okay, minor phase consists of similar to the abortive poliomyelitis, means like a viral prodrome, headache, vomiting, yeah, muscle pain. So like that of like a viral prodrome. And the major phase of illness begins with muscle pain, spasm, and fever. This is followed by rapid onset of flaccid paralysis that is usually complete within 72 hours. So there are three types of paralytic polio. Yeah, the first one is Spinal paralytic poliomyelitis. This is the most common one. It results from element type of lesion of anterior corner spinal cord and affect the muscles of legs, arms, and trunk. The affected muscles are flaccid, as in element type, and reflexes will be diminished in element type of pulse. This is most important slide of this lecture. Okay, there is no sensory involvement. Okay, this will help in distinguish from the Guillain-Barré syndrome. Yeah. So Guillain-Barré syndrome is an old term. It was named after the scientist. Now most of the examiners prefers to call GBS as AIDEM, acute inflammatory demyelinating polyradiculopathy, AIDM. Yeah. So paralysis is often asymmetrical, okay, and affecting legs more than arms. Paralytic manifestation in extremities begin proximally and begins to involve distal muscle growth, that is descending paralysis. Severe cases may develop quadriplegia and paralysis of the trunk, abdominal, and thoracic muscle. And residual flaccid paralysis usually present after 60 days of infection. So this is very important slide. And again we will see the slide in the coming lecture. See, there is no sensory involvement. Paralysis is often asymmetrical, affecting legs more than the arms. Paralytic manifestation begins proximal muscles. Okay, this slide is very important. So the second type is bulbar poliomielitis, which infecting the cranial nerves. Okay, cranial nerves resulting in vagus nerve is involved. What happened? Respiratory insufficiency. There will be difficulty in swallowing, nasal regurgitation, and difficulty in phonation. And bulbospinal means combination of both spinal and bulbar. It occurs up to 20% of paralytic cases and combination. Yeah? So this is called residual paralysis. As acute phase of illness, that is paralytic polio, subsided, the recovery began in paralyzed muscle. The extent of recovery is variable depending upon extent of damage caused by the neurons by the virus. The maximum neurological recovery of the paralyzed muscle take place in the first 6 months of the illness. Okay, but slowly recovery will continue because we have to go for physiotherapy. Yeah? Continues up to the 2 years. After 2 years, no more recovery is expected, and child is said to have post-polio residual paralysis, which remain as throughout their life. This is more pathetic because they will left with some residual paralysis. So we commonly see that it affected most the limbs, how the child will look like. Yeah. So we will come from muscles that lift the foot. They will have foot drops. The muscle will be wasted. You see that how thin when compared to other ones. We already learned this is asymmetrical because there will be some difference between both limbs. See, this limbs is how thin, yeah, and they develop contractures. These contractures, and they not able to flex or extended completely. Yeah? And spinal muscles also, if infected, then will lie to one side. If shoulder muscles are so involved, see, this is asymmetrical involvement. Already we learned polio. See how wasted it is, how thin it is. Yeah? So this is post-polio syndrome. Yeah, because polio has infected 2 years when he has some residual infection, residual paralysis. So he is continuing his life with this defect. But after few years, again he get trouble. Why? Because maybe due to the aging process. See, in some individual, it has been observed that there is clinical deterioration among the survivor after several decades. Yeah, there is recent muscle weakness, poor adherence, fatigue, and muscle and joint pain. Okay. So exact pathogenesis of syndrome is not known, but it is attributed to the combination of aging process and muscle degeneration due to the increased metabolic demand. Yeah? So these are the new, that is VAPP means vaccine associated paralytic poliomyelitis. In some of the recipient of OPV, in less than 1%, some genetic changes are occurring in the BP1 gene of the vaccine virus take place. So this vaccine, because what we give oral polio is attenuated one, yeah, attenuated, less harmful, but some genetic changes is occurring, yeah. Vaccine virus become virulent and cause paralysis in the same recipient or among close contact who is not immune. Approximately one case of EAPP occurs after 2.3 million of first doses and after 1 million of subsequent doses. Yeah. So according to WHO, approximately 500 cases are reported every year. EAPP is clinically indistinguished from the paralysis due to polio virus. Clinically, it will be very difficult whether it is causing wild polio or vaccine associated. Only by the microbiological studies, by genetic sequencing only will come to know whether this is caused by vaccine associated or it is by wild polio virus. So this is VDPV, means vaccine derived polio virus. So it is the derivative of Sabin strain from OPV, which exhibit 1 to 15% of genetic changes in BP1 gene and usually transmit disease to non-immune individuals. Okay, the strain has potential for human infection and paralysis, including sustained circulation and spreading diseases in other countries to human travel, and there is serious threat to spread of the disease in various countries of the world. That's why they have, because surveillance will go in every place, they will select some places. In Telangana 2006, from a Suez Canal, the surveillance take place and they have detected VDP, vaccine derived polio. So they have given almost 4 lakhs of people living in Telangana giving the IPV. We already learned. So vaccine derived polio virus and vaccine associated paralytic polio, these can be overcome only by IPV, that is inactivated polio virus. Okay. And this mutant strain is of 3 times. So what are the differential diagnosis? This is the most important topic for the 4th year student, because this is differential diagnosis, because I have not seen up to now any polio virus, poliomyelitis, because it was eradicated. We want to know the differential diagnosis, yeah, in which case you have to suspect and you have to refer to the medical officer. Okay, so 4 important differential diagnosis. Yeah, paralytic poliomyelitis, GBS syndrome, Guillain-Barré syndrome. Already I learned it called AIDP, and traumatic neuritis and transverse myelitis are the most common cause of acute flaccid paralysis. So this is an important table. Yeah, we already learned this, and again we'll go revision of it. Okay, signs and symptoms. These are the 4 ones. Yeah, poliomyelitis, GBS, transverse myelitis, and traumatic neuritis. Yeah, fever at onset. We have learned that in minor paralytic to major and minor. Major, after major phases, sometime after we get minor, and at that time there will be fever, yeah, high grade of fever. In GBS, it is not common. But mainly we'll see these 2 different, because the examiner will ask these 2 main. Transverse myelitis will come to know some accident. Traumatic neuritis also will come to know because the child has fever, he underwent some procedure. Okay, so we will go these 2 differences. So flaccidity, again, asymmetrical and proximal. Yeah, symmetrical and distal. Yeah, this is called descending paralysis. This is called ascending paralysis. And DTR, decreased absence, and it is absent. Sensation, myalgia, no sensory loss. Here there will be a sensory loss. That tingling, hypoanesthesia of palms and soles, and it depends upon the extent of involvement of spinal cord. Yeah? Cranial nerves only in bulbar and bulbospinal. Cranial nerves are most common infected. In CSF means cerebrospinal fluid. White blood cells are increased. These are less than 10 WBC. CSF protein, there will be slightly increased, and this is very high. Bladder dysfunction, there will be absent. Here there will be transient. They again recover the bladder function. And abnormal NCV studies, we already know it is abnormal. This is abnormal demyelination. We already learned GBS. Other name is acute inflammatory demyelinating. This is demyelination. Polyradical. EMG third week is abnormal because the paralysis is residual paralysis will be permanent. Yeah, some post residual will be also present. They usually acute usually they will weaken. Yeah, normal. So here is important is less than WBC, CSF and protein is very high. This is called albumin cytological dissociation. Okay. So other some important differential diagnoses include hypokalemia, encephalitis, meningitis and other enterovirus infection, poliomyositis and peripheral neuritis, myasthenia and other myopathies, etc. When we see these kind of cases, we have to report to the surveillance officer who is a medical officer. Okay. So again, these are the most take-home message for the classes is only this slide. Yeah? Distinguished characteristics of paralytic polio are asymmetric. Yeah, acute flaccid paralysis, lower type element type of lesion, mostly involving proximal muscles, that is descending paralysis. We get myalgia at the onset, muscular pain, and there will be rapid progression within 72 hours. Yeah, usually within 4 days. And there will be intact sensory nerve function. Okay, in GBS only we lost the sensory function. And there will be some residual weakness after 16 days. In GBS, usually they will re-get their weakness. So clinical diagnosis. Element type, asymmetric paralysis without any sensory involvement. Yeah. How can you, so whenever you see any AFPP cases, what we have learned, poliomyelitis, GBS, traumatic myelitis, transverse myelitis, hypokalemia, encephalitis, polymyositis. Whenever you are getting any flaccid paralysis, the stool should be sent, okay, for the virus isolation. So 2 stool specimens are collected from each case for laboratory confirmation. This is very important for community medicine. They will ask, how do you know that is adequate stool? We have received adequate stool specimen. Yeah, 2 specimens collected at least 24 hours within 14 days of onset of paralysis. Each sample should have volume 8 to 10 grams or thumb size of the patient, and sent to a WHO accredited laboratory in a good condition with no desiccation, leakage, and maintaining a cold chain. Okay. For collection of the stool, it should be a normal voided. So don't give any stool softeners for the motion or any anemia because the lab won't accept it. It should be a normal voided stool. Whenever you collect the stool, it should be kept in the freeze and immediately intimated to the surveillance officer. So what is the treatment? You know that viral infection treatment, mostly it is supportive. Yeah? The aim of treatment is to promote recovery and to minimize the residual muscle paralysis and disability. Okay. Children with bulbospinal means those are involving cranial nerves, so respiratory vagus nerve, so respiratory paralysis may require hospitalization and ventilation. Yeah? In acute stage, children with isolated limb paralysis should be advised complete rest, proper position of the affected limb, and passive range of movement at the joint. Massage and IM injection should be avoided during the acute phase of illness. Okay. So this is called warm, moist fomentation and passive range of movement of all joint, affected limb, and limbs should be given. This is we call it sister Kenny treatment because this sister pioneerized in the polio care of the children. So for her we have kept this thing. So at acute phase of illness subside, recovery in muscle power is helped by giving physiotherapy in the form of active exercise aimed at strengthening the weak mind, improvement of functional skills of the chain, helping ambulation and prevention of deformity. Physiotherapy play an important role in the management of children during the recovery and post-polio paralysis, post-polio residual paralysis. Some children with fixed deformity and contractures may require some orthopedic surgery. Okay, so this is a very important one. So we have learned poliomyelitis. It will cause permanent residual paralysis. Yeah? So how can you prevent? You can prevent it by giving the vaccine. There are mainly two types of this: bivalent, no, we'll tell poliovirus and IPV, inactivated poliovirus. Previously we have trivalent. Now we go to bivalent. So bivalent, it contains only OPV1, V1 and OPV3. Yeah, OPV2 we have removed from the vaccine. Yeah? Why? Because this is one of the most common causing the VA vaccine derivative poliomyelitis, paralytic polio. So this is very important. Examiner may ask you, every point is important. Now we are giving bivalent. Okay. So oral poliovirus given by oral, 2 drops. Okay, this is first we'll go for. So when we give at birth and again at 6 and 14 weeks, and 2 booster doses at 15 to 18 months at 5 years. Okay, dose was given at birth within 2 weeks, and second 6, 10, 14, and again 15 to 18 months and 5 years. This is national program which is given in all medical college and in a government hospital at free of cost. Why it is called 0 dose? So it is not protected from polio infection, but it helps during seroconversion. So we call it as the 0 dose, and it does not account while taking count. We call it as only 0 dose. So 3 doses, 6, 10, 14. Okay, this is a IAP where we given in private clinics at about 6 months, 9 months, and 5 years. So catch up means if they are up to 5 years, we can give 3 doses 4 weeks apart. Those who have not received vaccination, so up to 5 years we can give 3 doses. What are the adverse effects? We already learned vaccine derived poliomyelitis and vaccine associated paralytic attacks. OPV2 is most common, so we have it, but OPV3 also. We are coming graded. Graded, we are taking one of the strain from the polio vaccine. What are the contraindications? Inherited and acquired immunodeficiency and symptomatic HIV we should not give. Okay. Storage also cold chain we need to make, very sensitive to heat. So we have vaccine by monitor. In coming slides, I will tell you about VVF. Yeah. So this is inactivated poliovirus. Okay, means this one kill. So here 2 doses. Here it depends upon the route. Yeah, 0.5 ml IM or subcutaneous, 0.1 ml intradermal. Okay, it depends upon the. If it is intradermal, we give only 1/5 of the IM dose. Okay, and national program. Why national? In national program, the government advised to give 0.1 ml intradermal at 6 weeks and 14 weeks, and at the 10th week, we have to give OP or 1 full IM dose at 14 weeks. Okay, do not confuse this day. If you have IPV, you can give at 6 weeks and 14 weeks. Sometimes IPV, there is some shortage in some centers. If IPV is not available at 6 weeks and 14 weeks, we will give OPV at 6 and 14 weeks. Okay, or 1 full dose of IM dose at 14 weeks. What does IAP is telling means Indian Academy of Pediatrics. Okay, what they are telling, only 2 doses of intradermal is not effective. It's not 100% effective in preventing the poliomyelitis. Okay, what they advise is 3 doses of IPV at 6, 10, and 14 weeks, or 2 doses at 8 and 16 weeks primary, and 1 dose at 15 to 18 months. Yeah, government, this is our national immunization schedule. Yeah, 6 and 14 weeks. Okay, this is doing private. What they are saying, it is not 100% protect. So they are giving one more one. Yeah, what I said was local pain and swelling. These vaccines, why we have started giving it, these doses will prevent from vaccine-derived poliovirus and vaccine-associated paralytic poliomyelitis. So this inactivated polio vaccine has come to our schedule. Okay, and also this is also heat sensitive, and this also having vaccine by monitor. So this is our government supply. We contain a lot of. I think we can give roughly 20 children, 2 drops. We have to remove 1 kid. This is called VVA. I will let you know what it is. And this is the private one, because we use in private usually less numbers go for vaccination. This contains less one. And this is IPV. These are individual pre-filled 0.5 ml, which were used for individuals. Okay, sometimes we in private we get in combinations with hexaxine, hexavalent vaccines, and are also isolated IPV vaccines. This is government where used to give. It varies, because if you want to give IM, it's take 0.5 ml. If you want to give intradermal, 0.1. So it can be very good amount of volume, so that multiple numbers can be vaccinated. It also contains a VVM marker. Yeah? So this is VVM marker. This they will definitely ask exams. Okay, this is vaccine while monitored. What happened is OPV is unstable. When you expose to heat, these virus will go mutation and they will harmful to the subject. So we do not know whether they maintain in cold chain or not. So that this is sensitive to heat. So when they expose to temperatures, then they will change the colors. Okay. This will help us. So whenever we giving any vaccine in PHC or in our college, we used to see the VVM, vaccine while monitor, for the color. This inner square will be white and circle will be blue in color. So some mild change is there, but also it is okay, good. If no distinction is made, or inner circle, inner square become more prominent than the circular color, then it is bad OP. Okay, so first two you can do vaccine. Even this vaccine, sometimes they will call this is a heat monitor, but name will be vaccine by monitor sticker. Yeah. So this is polio eradication and endgame strategic plan. This is done in 2013. Your OP guide is still following this one. We are in 2020. Actually, new policy has came 2019 to 2023. So we will not go through it. Okay. So we have seen, because we are back of planning. Yeah, there was plan to suggest an bivalent OPV and continue only IPV, but still we are using bivalent and IPV. So this plan was again rescheduled to 2019 to 2023. Okay. So this is the polio end game strategy 2019 to 2023. This eradication, integration, certification, and contamination. Okay, this depends upon the core objectives. Okay, one more thing I want to tell you is that National Pulse Polio Program. Okay, because we used to get, because every child, yeah, below 5 years has to be vaccinated against the polio. Okay, when you come to literature, for developed countries, 3 doses of oral polio has given active %. But our studies say we need at least 7 to 8 doses of polio to protect from the poliomyelitis. So this is the one national immunization where every child is get immunized on intermittent, because they will attend some 6 months, 10 months. So they have started a program national pulse polio immunization, sudden mass immunization at the same time. Okay. So I will receive call from the patient. Sir, I have received pulse polio last week. Do I need to give? Yes, you need to give. Sir, we usually take IPV injection at a private clinic. Do we need to take national pulse test? Every child in this country below 5 years should take national pulse polio drops. Okay, it usually takes place in December and January with 4 to 6 weeks apart. Okay, why we have given that period is during in our country the poliomyelitis peak period is June to September. So before the peak we have to give or after the peak. So December and January where the infection rate of poliomyelitis very less. So we have giving the drops at that time. And please mind, every child should receive. There is no time gap. If they received 2 days before also, they should take the national pulse polio vaccine. Does diarrhea is a contraindication for polio virus? No. During diarrhea time also, they are advised to take polio drops on that day. Okay. So I have finished my topic. If you have any doubts, please ask me. We will go through it. And take home slide is this one. Where is that? Take home slide. Yeah. Yeah. This is the take home. No sensory environment. Okay. If you have any doubts, please ask me. Okay. Thank you.